It's a wonderful job to be a psychiatrist, and it's a very exciting time to be involved in understanding schizophrenia. We have had tremendous advances in the understanding of schizophrenia in the last decade. We now know many of the genes which predispose to schizophrenia, and we also know the risk factors which increase the propensity of someone to develop schizophrenia. And we're beginning to understand how the genes and the risk factors impact on the pathogenesis. And perhaps most importantly, we've begun to realize that this man was wrong. This is a picture of Emil Kraepelin. And when he coined the term dementia praecox in 1896, and he described the course of dementia praecox, which we call schizophrenia, as one of inevitable deterioration, a progressive disease from which few recovered. And this is not true. Perhaps it was true in 1896, but in 1896, patients with diabetes died. And modern endocrinologists do not regard diabetes as an immediately fatal disease. But sadly, many psychiatrists still believe that schizophrenia is a progressive disorder because they have this peculiar attachment to what Kraepelin said well over a century ago. So why is it that we still believe that? Well, one of the reasons is that the first brain imaging studies way back in the 1970s showed that people with schizophrenia did have larger ventricles and less cortex than the general population. And this was taken as evidence of the dementia, the idea that people with schizophrenia started with a normal brain, and then it deteriorated. In the 1980s, we in the UK, Sean Lewis and I, and in the United States, Danny Weinberger, said that these brain changes are not degenerative, they are developmental. And partly to my surprise, this became widely accepted. So the neurodevelopmental hypothesis became the predominant theory of the origins of schizophrenia. So the people who believed in the Kraepelin deterioration, they were vanquished. They were buried, but they did not die. They lay underground, waiting to come out again. And unfortunately, in 2005, these pessimistic Kraepelinians came out of the grave and started saying again that schizophrenia was a deteriorating disorder. And the reason that they did this was because of a study which showed, is there a pointer? Kraepelin didn't have a pointer. Why should I have a pointer? Okay. So you can see that in the grey. Oh, very good. Thank you. This is high technique. So these are sequential brain scans over 2 years of people with their first episode of schizophrenia. And the people in grey, that is the change in their on their cortical volume if they are on haloperidol. And you can see that their cortical volume decreased. Whereas in the black, you can see people who were on olanzapine. And Jeff Lieberman, who was the first author of this, interpreted this as indicating that schizophrenia was associated with a decrease in cortical volume, which was prevented by olanzapine. He then toured the world, courtesy of Eli Lilly, explaining this point of view. But of course, there is another explanation, and that is that haloperidol causes a decrease in cortical volume, and olanzapine less so. As a result of this paper, colleagues started writing papers about schizophrenia being a progressive brain disorder. For example, René Kahn or Celso Arango. But fortunately, the evidence that this was not true came in 2008, and this is a study by Beng Ho and Nancy Andreasen. You can see Nancy Andreasen up on the left there. I don't know the name of the horse, I'm afraid, but what they did was to study people who had repeated brain scans, repeated MRI scans for up to 13 years and see what happened. And on the left, you can see the red is a decrease in the volume of the cortex. And this is in people on a very large dose of chlorpromazine, CPZ equivalents, 929 chlorpromazine equivalents. So if you're on a lot of antipsychotic, you lose cortex. If, on the other hand, you're only on 115 milligrams of chlorpromazine equivalents, you lose relatively little cortex. So this produced a lot of controversy, and people said, of course, maybe those who are on a lot of antipsychotics have a very severe illness, and it's the severe illness that's causing the deterioration, and those who are on a small dose of antipsychotic have a mild illness, and this is probably true. But subsequently, there have been animal studies which have demonstrated that haloperidol and olanzapine do indeed have a detrimental effect on the cortex. So this is a study where Dorf Peterson and David Lewis took a series of monkeys, and there were 3 groups. One was a control group, one got haloperidol for 18 months, and one group got olanzapine for 18 months. And what they found was that those on haloperidol or olanzapine lost between 8 and 11% of their brain volume and brain weight. This has been replicated in other animal studies, and also been shown that if you do MRI studies, for example in rats, measure the decrease in the cortical volume on an antipsychotic, then stop the antipsychotic, then the cortex recovers over the next 8 weeks. So we do know now that these brain changes, which were thought to be part of the intrinsic deterioration of schizophrenia, are in part due to antipsychotics. And I'm very pleased to see Dr. Vita here as the discussant. I didn't know he was going to be the discussant, but what could be better than to show a slide of a paper by your discussant? I'm sure he'll say something nice about me now that I have shown this slide by accident. So what Antonio did was to do a meta-analysis of a huge number of studies of people with schizophrenia looking at the effect of antipsychotics. And I imagine you can't see this, but if I read the bottom, it says that there was more grey matter loss in those people on a high dose of antipsychotics, particularly if it was a first-generation antipsychotics. So the amount of cortex that was lost was less in those on a lower dose and less on those on atypicals. So now we know that antipsychotics do have this effect on the cortex, and there is a compensatory ventricular enlargement. We know that there are other effects also: cannabis, abuse of other drugs, and some of the illnesses that people with schizophrenia get, diabetes, hypertension. These also have an adverse effect on the brain, but it is nothing to do with any intrinsic deterioration in people with schizophrenia. There's no intrinsic schizophrenogenic deteriorating process. So if we look at patients with psychosis and with schizophrenia in particular and follow them up, what happens to them? This is a study called the Esop Study, where we, in 3 centres in the UK, collected all first episode psychotics. And we were able to follow up over 400 of them after 10 years. So that was, excuse me, we got good information on 387. Well, how were they functioning at 10 years? They were functioning surprisingly well. I should say that 70% of these patients had schizophrenia or schizophreniform disorder, 25% affective psychosis, and 5% various other psychotic conditions. But out of the total sample, at 10 years after their onset, 65% had no psychotic symptoms. So 2/3 of the patients, after 10 years, had no psychotic symptoms. 46% of them had had no psychotic symptoms for 2 years. And that was, of course, of all of the psychotics, but of those who had a diagnosis of schizophrenia, 40% of them had no psychotic symptoms. Now, of course, some of them were taking antipsychotics. About half of those who had no psychotic symptoms were taking antipsychotics. But 21% of the patients as a whole and 19% of those with schizophrenia had no psychotic symptoms at 10 years and were not taking any antipsychotics. So drug companies may tell you that schizophrenia is a disease that you have for life. It is not true. And it is not true that you have to take antipsychotics for life. A proportion of patients will be able to stop their antipsychotics and not relapse into psychosis. So a few years ago, Bob Sapersky and I summarized this view. It is a myth that schizophrenia is a progressive disorder. And it is a myth that is propagated by the pharmaceutical companies, that we have to continually intervene to stop deterioration. And it's an excuse for psychiatrists for bad treatment. If your patients deteriorate, this is not due to an intrinsic deterioration in schizophrenia. Much of it will be due to bad treatment. So the clinical outcome is better than we think. There is no evidence of intrinsic brain changes. There's no evidence of progressive cognitive changes. I didn't have time to go into this, but there's now meta-analyses following up people with their first episode of schizophrenia for more than 5 years, and these patients, on average, their cognition slightly improves rather than deteriorates. So what is the basic driver of the psychosis? Well, we know it is dopamine. Dopamine is the final common pathway for many of the symptoms, the positive symptoms of psychosis. And for a long time, we thought the abnormality was in the D2 receptor. So for 30 years, people were looking at the D2 receptor, thinking that the abnormality was in the D2 receptor. But in fact, we know that that's not true, perhaps except in drug-induced psychosis, and Dr. DeForti will talk about this. But most patients with schizophrenia, the abnormality is not in the receptor, but the abnormality is presynaptic. People with schizophrenia, people with psychosis, synthesize too much dopamine and release too much dopamine. There's now lots of PET scan studies that have shown this, that when people are psychotic, they're releasing too much dopamine. So what we do is to block this excess of dopamine. So there is excess dopamine synthesis capacity in the striatum, too much dopamine is released, then we give antipsychotics and they block the receptors. but they do not address the primary abnormality. The primary abnormality is not on the receptor, which we're blocking. The primary abnormality is presynaptically. It's effective. It decreases it of course decreases the psychosis. What causes the increase in the synthesis and release of dopamine? Well, stress is one factor. And this is a very interesting study from Canada by Dr. Mizrahi, who gave a stress test, a very difficult arithmetic test to a whole series of normal individuals. And it's actually quite I'll explain the test. You have to do arithmetic, and they tell you you're wrong even when you're correct. So you have to do various complicated addition and multiplication sums, and sometimes when you get it correct, they still tell you you're wrong. And they tell you, we're going to publish the results, and all your classmates, they will see how badly you did. And then they say, you're doing really badly. Everybody else is doing much better than you. Can't you try harder? So people get very, very stressed. And controls release a little dopamine. You can maybe see it in blue. I'm not sure if you can see it. But people in the prodrome, people who are on their en route to psychosis, have the at-risk mental state, transient psychotic ideas which disappear, they increase, they release more dopamine. They synthesize and release more dopamine. But people with schizophrenia, when they are stressed, they release more dopamine. So we know that stress increases dopamine, but not just immediate stress, but we know that the risk factors for schizophrenia, well, what are they? Risk factors for schizophrenia, things like child abuse, things like migration, things like abuse of amphetamines, abuse of cannabis. All of these factors impact on dopamine. So we know that the risk factors are causing this increase in dopamine, which is causing the symptoms. So you can have a model like this. People with psychosis, people with schizophrenia, they have a sensitized dopamine system. For biological reasons, because of their childhood adversity, when confronted with stress, they release too much dopamine. When you release too much dopamine, you get perceptual abnormalities. Things become louder, things become very salient, very significant, and and you begin to wonder why are you having all these strange experiences? Many people who have psychosis have had to confront a lot of adversity. They've perhaps been abused in childhood. Perhaps they've been migrants and discriminated against. Perhaps they've had adverse life events. And so they learn that bad things happen to them, and they learn to blame other people for them. So they then interpret these abnormal stimuli in a paranoid way. They think these things are happening to me because people are causing it to happen to me. They develop psychosis. Once you develop psychosis, you think your parents are trying to poison you, or the doctors are trying to kill you. This is very stressful. Therefore, you release more dopamine. You release more dopamine, you get more perceptual abnormalities, you become more psychotic. Eventually, one of you is the patient comes to see one of you, and you perhaps admit them to hospital, or admit them to some facility for care, some strange place where the nurses insist on giving them antipsychotics. You're convinced that you're being poisoned by now. Therefore, you release more dopamine. So you get into a vicious circle of increasing stress and increasing dopamine release. What we can do, of course, is we can block the increased dopamine release, or we can try and decrease the stress, or we can give CBT or other psychotherapies addressed at causal factors such as child abuse. And in the vast majority of cases, this works and people recover. However, about a third of patients in our Esop study continued to have troublesome symptoms. The two factors were, one, continued abuse of high-potency cannabis, and some of them were treatment resistant. And there's now ample evidence that the best thing you can do for your patients is to try and help them to stop taking drugs. That this is the major causal factor of schizophrenia that is preventable, and patients will continue to have symptoms as long as they take cannabis. This is a meta-analysis done by Tabia Schuyler and ourselves, and this found that continued cannabis use after onset of psychosis predicts adverse outcome, higher relapse, longer hospital admissions, more severe positive symptoms. If people stop taking the cannabis, then their outlook is much better. But what about people who are treatment resistant? So some people do not respond to dopamine blockade. Well, why is that? You can do a PET scan and you can look and see, these people who don't respond to antipsychotics, do they show the excess dopamine that you normally get in psychosis? So here on the left in the pink is the dopamine synthesis in healthy volunteers. In the blue are the people who respond to antipsychotics, so they are producing too much dopamine and we block its effect with antipsychotics. So we understand the pathogenesis and we have a treatment for it. But here in the purple are people who are treatment resistant, and they don't show a significant increase in the dopamine. So they don't have a dopaminergic abnormality. So if you have people who are not responding to antipsychotics, by giving them antipsychotics, all you're doing is causing them more side effects. Why are they psychotic? They are psychotic because they have a glutamatergic abnormality. So here on the left in the pink are healthy volunteers. This is glutamate in the anterior cingulate. In the blue are people who respond to dopamine blockers. They don't have anything wrong with their glutamate system in the anterior cingulate at least, but the people who are resistant to dopamine blockers and have a normal dopamine synthesis, they have an excess of glutamate in the anterior cingulate. So treatment-resistant patients show normal dopamine but elevated glutamate. And the interesting thing about these treatment-resistant patients in our Esop study, when we followed them up for 10 years, that 4/5 of them had been treatment-resistant from the beginning. They never responded to dopamine blockers. So these cases have probably suffered neurodevelopmental damage and got a primarily glutamatergic abnormality. But 18% of these treatment-resistant schizophrenic patients started off responding to dopamine blockers, but gradually lost that ability and eventually ended up being treatment-resistant. We now understand why this happens, because if you give dopamine blockers to animals, they gradually lose their effect. This is a study by Satish Kapoor and Phil Seaman. You give rats antipsychotics continually, then eventually you get upregulation of the dopamine receptor. The receptor is normally being bombarded with dopamine, but this effect is blocked by the antipsychotic. The dopamine receptor responds by increasing density, upregulating, and therefore becomes supersensitive. So this means you have to give more antipsychotic. And sometimes there will be a breakthrough. You're not giving enough antipsychotic. You get breakthrough supersensitivity and undermines the treatment efficacy. Now, for a long time, this has been suspected, but it seems very likely that what is happening, that the dopamine blocker is causing supersensitivity of the postsynaptic receptor and the signaling pathway distal to the receptor. So some patients develop supersensitivity to the D2 receptor and become treatment resistant. And this has been written about actually for 30 years by a Canadian called Chouinard. And there's also the question that why do we keep giving antipsychotics? Are we giving antipsychotics to treat the primary abnormality in schizophrenia, or are we giving the antipsychotics often to treat the supersensitivity that we have caused by giving the antipsychotic? So people with schizophrenia start off with having a presynaptic problem, and we compound this by giving high doses of antipsychotics, which cause supersensitivity postsynaptically, and therefore you have to keep giving antipsychotics to prevent the effect of this supersensitivity. So let me conclude. There is no evidence that schizophrenia is a progressive brain disorder. There's no evidence either from the imaging, there's no evidence from the cognitive studies, there's no evidence from the clinical studies. Most people with schizophrenia, most psychotic patients, the abnormality is consequent upon excessive synthesis and release of dopamine, and many social factors are provoking that increased release in people who have a predisposition. And that's why these people respond well to dopamine blockers, and they respond well to psychosocial interventions to try and decrease the stress. However, a minority of patients are treatment resistant from the start, and they are probably the ones who have neurodevelopmental damage. So it's not that the majority of patients have neurodevelopmental damage, a proportion of them have, but these are the ones who seem to have a glutamatergic abnormality and don't respond to dopamine blockers. It's not that they deteriorate, it's just that they were never responding very well. But finally, a small proportion of people with treatment resistance develop the treatment resistance because we're giving too high doses of antipsychotics and we cause a supersensitivity. So we compound the dopaminergic abnormality, start off with a presynaptic dopaminergic abnormality, end up also with a postsynaptic dopamine abnormality, and you're forced to keep treating patients. If you've given 20 milligrams of haloperidol, you're making it more likely that you will have to keep giving high doses of antipsychotic to treat the excess supersensitivity that you've actually caused. So let me say that I think now it is an exciting time to understand the causes of schizophrenia, but it's also a very hopeful time for our patients, that if we can provide them with good pharmacological treatment and good psychosocial interventions, then I think the vast bulk of our patients with schizophrenia should have a much better outcome than they've had in the past. Thank you for listening. Stummer wir sind immer